Bismillahirrahmanirrahim. Assalamu alaikum warahmatullahi wabarakatuh. Welcome everybody on the board. Today, the World Kidney Day. So I'm going to present about acute kidney injury. It would be rather more like practical tips what we really feel when we come across the patients who have acute kidney injury. We will be discussing about the definitions, some epidemiology and different criteria for the definition, and common causes of acute in the ICU, and how we approach the patient, like the management, and when should we start the renal replacement, what modality and what is the dose, and some of the bundles and the guidelines, how can we prevent this in the ICU. Background: acute kidney injury, previously, it was called acute renal failure, but acute renal does not categorize different spectrum of the disease, because all acute renal failure patient was not at the same level. Then later on, it was replaced with the acute kidney that we will discuss inshallah. Up to 18% of all hospital admissions have acute kidney injury. And from the admissions in the inpatients, the mortality range between 25 to 30%. And between 20 to 30% of cases of AKI also are preventable. So there is, space to play hand to prevent. This is definitely some like 20 to 30% are preventable, so should we work on it. And prevention could save up to 12,000 lives each year. And definitely the huge burden on the healthcare system when it comes across the acute kidney injury. So what is the layman, like the common definition we describe as the abrupt decrease in the renal function that result in the elevation of the blood urine nitrogen and other waste products, and dysregulation of extracellular fluid and the electrolyte. This is the vague, how we describe acute kidney injury. There are different, definitions that developed over the period of time. For example, in 2004, the acute dialysis quality initiative, they come across the first, the detailed definition that's called risk, injury, failure, loss, and end-stage renal disease. This was basically two things: the elevation in the creatinine and the urine output. This was the first step that was taken to describe the spectrum of the disease, that's the acute kidney injury, depending upon the severity of the disease itself. They know that there is some shortcoming in this criteria, so they come across a new criteria that's called the Acute criteria. This was developed with the acute kidney injury network, and they focus the deficiency of the previous RIFLI criteria, because in this criteria they also include the less severe form of acute renal failure, and they impose a time constraint that's of the 48 hours to 7 days, and allowing for correction of volume status and obstructive causal failure prior to classification. So this was the deficiencies that was found in the RIFLI criteria, and that was corrected by the Acute. This is just the comparison between these two things. In the Acute, they replace this RIF, like risk, injury, and failure, into the stage 1, 2, and 3. And later on the KIDICO, that's the kidney disease improvement in the global outcome. They come across, they combine both basically, the Acute and the RIFLI, and they come across the criteria. And they found that abrupt, within 7 days, reduction in the renal function that can be measured as like increase in the creatinine, even by 0.3 milligram per deciliter in the 48 hours. So this is like the time constant of 2 hours. So any patient admitted, if there is elevation of the creatinine by 0.3 milligram per deciliter in the 48 hours, this should be included in acute kidney injury. And also creatinine increased by more than 50% in the 7 days, within the 7 days, also following criteria of the urine output. Definitely, if more than 6 or if less than 0.5, it's also a criteria for acute kidney injury. This is as we discussed already. So here we decide that acute renal failure is replaced with the acute kidney injury. And acute kidney injury, all the acute kidney injury are not the same. We have different stages: stage 1, stage 2, and stage 3. depending upon the creatinine and the urine output and the duration definitely as well. So why we worried about the acute kidney injury? This is one of the study. Basically, this is a systematic review and the meta-analysis that were published, I think, by the Stephen J. Coca in one of the journal. It's combined different kind of studies, not like all randomized controlled trial. Only we can see only the two randomized controlled trial. Otherwise, the observation studies. But what they come across, they were able to prove that the patient who developed acute kidney injury, in these group of patients, the risk of progression to CKD at end-stage kidney disease is high as compared to other patients who don't have the episode of acute kidney injury. So if we see here, we see after having the hazard ratio and an instrumental variable, they found that the collective increase is almost 8.82 hazard ratio for CKD, and it's 3.1 as when come to the end stage renal disease. So what we know that now patient on acute kidney injury is not only the simple insult to the kidney itself, but the chances of progression to CKD and end stage renal failure is high in these patients. Also, another study meta-analysis, and what they found also here, not only the CKD, but even the risk of the mortality is high when it comes to general population who don't have the insult of the acute kidney injury. So acute kidney injury imposes a health burden in the favor of, in the form of a CKD, renal failure, and even increase the mortality. So when it comes to the outcomes that relate to severity as well, and depending upon the patient duration as well. So what they found that within the same classification of same degree of insult to the kidney, it means the stage 1, stage 2, and the stage 3. If the duration is increased, the mortality rate also increases. So here, whatever the insult was found from the initial was stage 1, stage 2, or the stage 3. If this stage persisted for a couple of days, each day the mortality will increase. But within the duration, no difference regardless of the stage. Okay. Sorry. So what the common etiology, as we know, we have initially we differentiate between the pre-renal, the intra-renal, and the post-renal of the etiology of acute injury. The pre-renal, the vascular diseases, the volume depletion, the hemorrhage, heart failure, abdominal compartment, hepatorenal syndrome, sepsis, and drugs that alter the renal hemodynamics. In the intra-renal acute necrosis, or interstitial nephritis, vasculitis, GTP, myeloma, glomerulonephritis, thromboemboli, and post-renal intrinsic or extrinsic obstruction. So, sometimes these are really helpful depending upon the diagnosis and the patient management, what is the main cause of acute injury in this patient. When it comes to the ICU, things are not that simple, because less likely the acute injury is coming as a solitary organ damage. Most of the time it's coming as a part of a syndrome, and most of the time we found that the kidney itself is a very innocent organ. Whatever other part of the body is damaged, kidney is affected secondarily. For example, in sepsis, the most common cause of the acute kidney injury, sepsis injury, nephrotoxic drugs, cardiorenal syndrome, hepatorenal syndrome, cardiac surgery associated with injury, or glomerulonephritis, obstructive and abdominal compartment syndrome. So in most of this, except some like glomerulonephritis, the problem was not in the kidney itself. Kidney was affected secondarily because of other organ damage. So when it comes to the diagnosis, sometimes we forget like the simple things and we move forward to the magic test. So sometimes simple urinary indices help us to differentiate not only the etiology and the cause, but also helpful for us in making the diagnosis and guiding the plan of treatment. For example, if the case of pre-renal azotemia disease, it should show normal, highly cost. But when it comes to the ATN, here we can see, we can differentiate because there is the epithelial cell cost and there is the MAR. This is found on the our initial analysis that one can know at least what is the reason of this patient having low urine output or kidney injury. So similarly, if there is WBCs or RBC and the cause, moving vasculitis or glomerulonephritis. And nephritis also we found WBC and UC cast and RBC's cast are found. And so if we have if we have WBC cast or if we have RBC's cast, if it's normal, at least can give us some initial idea. So what is the main culprit for kidney injury in these kind of patients? Also, urinary excretion is helpful in differentiating between the pre-renal and the renal. Here concept on the kidney itself is functioning well, definitely kidney is able to reabsorb more sodium. But if the insult is before the kidney, definitely kidney are absorbing well the sodium. But when the insult is inside, definitely kidney is unable to reabsorb well the sodium itself. Sometimes it also helpful. So this is apart from clinically that we have a low urine output, we have high creatinine, and our patient is sick because of some reasons. Yes, but this is the time when the kidney is already insulted. The part of damage is there already. So they come across researches that should be something like that, predict this activity before in time, like in other systems as well. So they come across the novel biomarker that can predict, okay, this patient will develop acute kidney injury, like the prediction of acute injury well before in time. So they're different, like for example, early diagnosis, they took the urine, they checked for the NGOL, NAG, KIM, interleukin 8, and the early prediction of development of the acute kidney injury, again NGOL, interleukin 6, and liver type fatty acid binding protein, and the production of urine, they come across the cystaceid. So a lot of studies are going on the novel biomarkers. For example, the NGOL. This is neutrophil gelatinine associated lipocalin. So this not only tells us that this renal injury is because of the intrinsic thing, but it also tells us the how probability of the progression of the disease and the severity of the disease itself. So it was helpful. So, but yes, recently they come up with of two markers that basically some books written like as a nephro check, and it's already a FDA in the Europe and some of the in the American countries to check, because it can well predict that this patient is going to have acute kidney injury. So it means well in time before the neurons itself got damaged. There is some changes and this biomarker released. So it means they can act early to prevent the acute injury. Because as we discussed from the beginning, there's 20 to 30% the cases, this is a preventable problem. So tissue inhibitor of metalloproteinase 2 and insulin-like growth factor binding protein 7, this is the combination that's called basically the nephrocheck. So what is the principles of management? We will come across some specific therapeutic interventions, but unfortunately, most of them are not appropriate while the patient in the ICU. General supportive measures, non-specific management strategies, and dialysis support. So we'll discuss them one by one. So the classic indication for hemodialysis in acute kidney injury are like if the patient has uremia, the azotemia, and the diuretic resistant volume overload, or refractory hyperkalemia and the metabolic acidosis. Again, it depends on our normal kidney function, what our body get the benefit from the kidney itself. If this is deranged in the severe hyperkalemia, acidosis, overload, or features of the urine, this is the classical indication for having dialysis. So question, which of the following is the most common cause of AKI in the ICU? And we discussed before, yes, definitely the sepsis is the most common cause of AKI in the ICU. Here again, I will emphasize that the kidney is an innocent organ, so there was no problem directly in the kidney, but the culprit was the sepsis itself. So the critical question that come across whenever we have a patient acute injury in the ICU, few questions we ask ourselves: should we start early or the late dialysis? And what the modality we should adopt? It's the continuous is better or intermittent is better, and how much the dose, the intensity. So we'll review some of the literature and we'll come across our opinion. Yes, this is one question: which is the most beneficial or the best venous success when we are planning for dialysis? So definitely the first choice is right jugular vein. It's not the femoral, it's the right jugular vein best. And second is the femoral, and third is the left jugular, and at the last is the subclavian. And that's recommended to use ultrasound guidance when inserting the dialysis catheter. So early or the late initiation. This has been a debate for the years, and during my training, were more enthusiastic to ask our police nephrology that we need early dialysis because this will prevent and blah blah blah. But at the end, there's no classical the benefit output. But yes, we'll use literature. Initially, this is a systematic review analysis that was published in 2011. They compare early versus late initiation of renal therapy in ICU patients. So here is the meta-analysis, and they found that early is a little better as compared to. But this we found this the huge heterogeneity in the this previous study what was done. So early institution of RRT may have a benefit impact. This new is based on heterogeneous studies of the variable quality, and there were only 2 randomized controlled trials. So definite treatment recommendation cannot be made depending upon these old previous studies. So then comes the other one of the most famous trial, the Elaine randomized controlled trial. Also, it compared the patients with early and the late, and it was only a randomized controlled trial, only 231 critical ill patient ICU in one of the hospitals in Germany in 2013 to 15. And what they found that early, within 8 hours of the diagnosis of PDQ stage 2, are delayed within 12 hours of the stage 3 AKI and no initiation of the RRT. It means early means PDQ stage 2, late mean already patient is stage before they are giving the dialysis. So among critical ill patient AKI, early renal compared with the delayed initiation of RRT reduced mortality over the first 90 days. But again, this was the single center based randomized control trial, not enough number on 231 patients. This is one of the most famous trial, I believe. That's the Kiki group. They was working on kidney injury, and they have made a steady randomized control trial in different hospitals, because that's a multi-center control trial. They assigned patient with acute kidney injury who require mechanical ventilation and some kind of vasopressors, or both of them. Early strategy renal replacement was started immediately after randomization. So already the patient is stage 3 and has one of the problem, either on ventilator or the patient is requiring some kind of vasopressors. So initially they start immediately randomization, they start with the RRT. Delayed mean RRT was initiated if at least one criteria was found. That's conventionally that we based on, like severe hyperkalemia, metabolic acidosis, pulmonary edema, BUN higher than 112, and oliguria more than 72 hours. The primary outcome in this study was overall survival at day 60. So almost it's comparable. The characteristics of both limb of the study was comparable. So what they found interestingly, that all the previous literature that was more in the favor of early start of renal replacement therapy. This could not be proved depending upon this multi-center randomized controlled trial. So they said there's no benefit of initiating the early renal replacement therapy. Rather, what they found here, if you see, the patient who was delayed for renal replacement, they have more days of renal replacement therapy. It means there was many patients that even if we can avoid if we had a delayed strategy. So again, we come across the classical indication of the dialysis, that we believe should be in our mind when we start the renal replacement therapy. So the concept of early was not justified, I think, at this time. So we agreed on this first point that there is no significant benefit of starting early renal replacement for the patient who are in the ICU until they have a true indication. Yes, the bedside assessment is one of the best assessment, but the studies could not prove the early initiation. The second modality, again, discussion went along through what should we do, the modality, should the continuous or the intermittent renal replacement therapy. So this is summary of the 3 meta-analysis that compare continuous with intermediate acute kidney injury, and but they found no consistent effect on the recovery of renal development of the sick. So they could not favor one on the other, that this is better and this is not the better. So the other there is one more study they shown that intermittent and CRRT, what is the effect on the fluid balance and the mortality. Here we have to smartly see that intermittent hemodialysis, when we prescribe a patient to the ICU, yes, they have more fluid accumulation as compared to the continuous renal replacement therapy. So the patients who are given intermittent hemodialysis, they have more net fluid balance as compared to the patients who are on the continuous renal replacement therapy. And indirectly, the patient who has more positive fluid balance, the probability of the survival was less as compared to the patients. So only the indirect, conclusion from the study, they found that intermittent modality result in the greater volume overload, which was associated with increased death risk. So we don't start early, but yes, we don't let our patient to be more on the positive side, because this fluid for some patient in the ICU, this is not a benign. This itself has some effect on the cardiorenal system and pulmonary system as well. So again, positive fluid balance and the mortality in the hemodialysis requiring patient in the ICU. Here again, the balance, that fluid balance, it also was noted more in the patients who are non-survivors as compared to the patient who was in the surviving. Not that much statistically significant, but yes, the trend is towards the patients who are not that much neck fluid positive has more survival as compared to the patients who are non-survivable. So the positive fluid balance is associated with increased mortality in dialysis requiring acute kidney injury patients. So when it comes to ICU, for example, when we prescribe a patient that this patient requires dialysis, so yes, we should consider multiple things in our mind. It's not only the kidney function or the classical indication for the dialysis that can decide this patient will go for intermittent hemodialysis or this patient will go for the continuous. Yes, we should keep in mind what the liver failure, the hypotension, the severe volume overload, and excessive obligatory intake. For example, the patient who is having hypotension, high pressures, so this patient definitely will only tolerate the slow, it means the low dose, it means the CRRT will be better tolerable in this group of patients as compared to the patient who are hemodynamically stable. Sometimes our colleague, the pathologist, they advise dialysis for 4 hours or 6 hours, they want to remove 2 or 3 liters. So it depends, because all the blood we are sucking is coming from the intravascular compartment, and sometimes we are doing pressures. So the chance of going to the hypotension and we have to discontinue dialysis is high. So this is the reason that not all patients will tolerate intermittent hemodialysis. But I believe in the practically, yes, in spite of doing 24 hours, sometimes just we extend 8 to 12 hours, and slow removal of the fluid that little better tolerated as compared to the regular 2 to 4 hour hemodialysis. So what intensity? Should it be conventional 25 ml per kg per hour? Should be 35? Which one is better? Yes, there is the study, a lot of studies I have done on this. And what they found, just quick, is two trials that in this regard are more important: the Aten trial and the renal trial. And according to the Aten trial, the patient receiving the intensive treatment means 6 times per week, they were given 35 ml per kg of body weight per hour, but compared to other patients who were receiving only 3 times a week, and those were only 20 ml per kg. And what they found, the statistically not a significant difference in the intensive therapy as compared to the usual care, means less intensive therapy. So no, the cumulative probability of the death from any cause, there is no difference whether you intensely dialyze a patient 6 times a week or whether you give only the 3 times a week. So again, it depends upon the patient condition itself and what is the indication. So let's we discuss. So again, according to renal study, again they went on the high dose and the standard dose. Study was the 90-day mortality. There's no difference. So there's no difference, no need to intensely like high dose dialysis. So if you're doing 3 to 4 times, depending upon the patient condition, and with the usual dose like 20 to 25 ml per kg, and this is the most acceptable thing. Yeah, a special category of the patient. Sometimes we have a patient who have cardiac type of surgery, and one of the common complications is being happen in the acute kidney injury because of the bypass, shock, or cardiac dysfunction, and some of the medication like called Erbrox medication, for example, the contrast, AC inhibitors, or AR, or ARBs, or NSAIDs, or some of the the antibiotics. Sorry, yes, I think this is some problem with mistake. So sorry. Okay, I think there is some shuffling in one of few of my slides. Yeah. So this is why I was mentioned, because one of the common complications that happen in the patient who underwent any kind of cardiopulmonary surgery, artificial surgery, because of these reasons. So how can we avoid these patients acute kidney injury? So this is basically the study, but I want to tell you, this was published in 2017. How can we prevent cardiac surgery acute kidney injury by implementing KIDCO guidelines? So this was the trial that was started previous AKI trial. They took only 276 patients and used biomarkers and intervention groups. They avoided nephrotoxin, they avoided hyperglycemia, they optimized fluid status and hemodynamics. And what they found, that hemodynamics to minimize volume status in interventional group, by avoiding fluids unless there was stroke volume variation and more anatropes in the intervention group. But the result was interesting. And after, in this group of the patient who were doing cardiothoracic surgery, by implementing KIDCO guidelines, that they found that AKI was decreased from 71% to 51% overall, and severe AKI decreased from 55 to 29.7%. There was significant reduction in AKI when they apply true sense the KIDCO guidelines to the patients who are going for cardiothoracic surgery. So we discussed this. Okay, sorry, I will just go back, and a few slides I missed, I will review. Okay, this would be actually at the end. So what about the KIDCO vendors? The high risk patient, for example, what is the advice by this kidney disease global improvement, global outcome? What they advise that discontinue all nephrotoxic agents when possible, ensure volume status and perfusion pressure, consider functional hemodynamic monitoring, avoid hyperglycemia, consider alternatives to radio contrast procedure. These are all advice to prevent the development of the AKI in these patients. Also, if the patient is stage 2, apart from the previous one, yes, we should non-invasive diagnostic workup. We will consider invasive diagnostic workup, and when it comes to stage 2, should check for the changes in the drug dosing and consider the replacement therapy and ICU admissions, and we should avoid subclavian line if possible. This we have discussed already. So there is, like, we all of us know we're using the paperless, right? We are using the system. So in the system, there are some alerts are developed to pay our attention that, okay, something is going wrong in this kind of patients. For example, we have a patient on the floor with any other systemic illness. They're too much about the creatinine and the renal function like this. So if we have alert system called clinical decision support system. So they went through studies, 528,000 patients. We don't have no end stage renal disease as per admission. And in these patients, because of this electronic alert system, they were able to diagnose 64,000 patients. So 12.2% patients were diagnosed having AKI because of the alert system. So after CDSS, mortality decreased from 10 to 9.4% in the patients with AKI. No change in the patient without AKI. So it means what they were able to do, they were able to detect or focus themselves earlier on the development of the acute kidney injury. For example, the patient who was receiving a nephrotoxic drug, whether it's the antibiotic. So if they develop early, so before patient enter into the advanced stage, I mean stage 2 or stage 3, oh, they were alerted, yes, this patient is having acute kidney injury. By the definition of 0.3 milligram per deciliter increase over 48 hours, that yes, we should think and other of antibiotics, other drugs that don't have nephrotoxin. So this is the reason that the alert system has the beneficial effect. So this also in the paper, but the European, what they say about the prevention of acute injury in the ICU, it was published in 2007. So what they have come across some of the recommendation, right? They controlled fluid resuscitation in volume depletion, while however avoiding volume overload. So yes, we have assessed the patient on the individual basis. Yes, one of the common reasons for the patient ICU develop acute injury is the sepsis, and definitely sepsis with volume depletion and hypotension. Yes, these patients need resuscitation, but in the careful resuscitation. And then recommend against the use of starches. Yes, most of us know more using the colloids in form of starch. Only we use albumin if we need. And we recommend correction of hypovolemia dehydration using isonic crystalloids in the patient receiving intravascular contrast media. So we have come across the different protocol hospital. How can we prevent the contrast-induced nephropathy? And we give some of the fluids, like sometimes we give like few hours start before hydrating the patient, continue for 12 hours, and sometimes we give just bolus fluid if the patient is tolerant to the fluid, just to avoid the contrast-induced nephropathy. And they would recommend regular monitoring of the chloride level, because it's assumed that chloride is not safe for this patient. So not all patient needs normal saline. Definitely some patients are better to give him the half normal saline and the ringer saline as well. We suggest the use of balanced crystallite for large resuscitation. So this is the common mistake that happened in the ICU company admitted the hypovolemic shock or DKA. So we are aggressive about hydration, and if we put like 3 to 5 liters of normal saline that contain enough number of the sodium and the chloride, so ultimately what we found that the patient has developed hyperchloremic metabolic acidosis. That's not basically disease, that's the complication of the resuscitation. So they're more in the favor of the balance, because for example, the ringer solution is more physiological as compared to the normal saline. So if we give normal saline, like want to add up, then we have to use again, we can use the half normal saline or the ringer solution. That's better actually physiologically. And we suggest using human serum albumin if a colloid is deemed necessary for the treatment of the patient. Patient not tolerant to too much fluids, we want to give the less fluid with more on-contact pressure. So albumin is the option, starch is not the option. No. We suggest prophylactic volume expansion with crystalloids to prevent AKI by certain drug specific below. This is just the best practice statement, which is not delaying urgent contrast and host investigation or intervention for potential preventive measures. So sometimes some doctors think that, okay, this patient needs study. For example, we have a patient who have high suspicion of the PE, and patient has like already the kidney injury. So we thought, should we go for the contrast study like CTP urgently, or because of the kidney injury we can delay like this? So they said no, we should take the precaution, but you should not delay, because definitely the consent. But on the other hand, we are missing the major diagnosis, and this the patient, for example, may need therapeutic anticoagulation or may need even thrombolysis. So all depends on the study. If the study is urgent, so risk and the benefits, you ask yourself, but just solely because of the reasons of the contrast-induced nephropathy, you should not delay that study. Diuretics, right? These patients who have acute injury, low urine output, sometimes, our colleagues, okay, low urine output, give Lasix. So this is not the practice always. So what they recommend against loop diuretics given solely for the prevention. So there is no role of diuretic just in the prevention. We are using diuretics to control fluid overload in patients that are diuretic responsive. So not all patients are diuretic responsive. Here, I mentioned my slides, but yes, sometimes I'm finishing now almost in 2 minutes. So called like furosemide test, right? Sometimes it's also a beautiful test that can differentiate that this patients who have acute kidney injury will develop in the stage 3 or end stage, that we give furosemide like 1 to 1.5 milligram stat, and we observe next 2 hours. If the urine output next 2 hours less than 200 ml per hour, it means this patient high probability of progression to the stage 2 or the stage 3 renal failure. Yes, sensitivity is more than like 80%, and specificity also at 7% for this. Yeah, vasopressin, yes, vasopressin should be, if needed, we should start vasopressin early. And vasodilator, yes, I mean, if the patient, depending upon the patient, yes, we can suggest like this. Here, the fluid, vasopressors, vasodilator, the background behind to provide adequate renal perfusion. Like the renal perfusion pressure should be the optimal. It's not only the numbers that the patient has high blood pressure and it's good. No, it's the perfusion pressure. For example, the patient has pulmonary hypertension now before, a patient had right heart failure and normal blood pressure, right? But his veins are congested. This patient don't need fluids. This patient need to de-resuscitate, because the renal perfusion pressure is minus central venous pressure. So if the venous pressure go high, renal perfusions go down because of the congestion. So in this specific set of the patient, either you start diuretics or remove the fluid early. This will improve the renal perfusion and progression of the kidney disease. So that's all that we already discussed already. Same. Thank you so much, Dr. Lafaira. If you have